So thanks for all those presentations. Now Dr. Mark Carroll, who is a senior consultant for the Focused Ultrasound Foundation, will present a tool that the foundation has developed to enable comparison of up to 6 different medical procedures in terms of their true cost to perform, as well as commercial and CMS amounts paid to perform them. So here's Mark.
Thanks, Jessica. Thank you, Jessica. And thank you for all of you who have stayed around for an actual live presentation. The last time I gave a live presentation, there were 6 people in the audience, so today is a step up. Neil Cassell has been a tremendous proponent of trying to increase the use of focused ultrasound technology clinically. And knowing my background in prostate cancer, having been CEO at Sonoblate, he approached me with the thought that if we knew how much it really cost to do a procedure, that we would be able to show that focused ultrasound costs less than the competition. So he asked me what he thought was a very simple question. How much does it cost to do the various procedures for treating prostate cancer? I knew from working with hospitals as CEO at Sonoblate that unfortunately this was not an easy question to answer. Hospitals actually don't know what it costs them to do procedures, let alone how to charge for them. And as was noted in Mike Broad's presentation before this, knowing the true cost of a procedure is critical because it is used by CMS to determine the payments. So I set out to work on what turned out to be a massive project to figure out what things cost and actually to apply it to all of the indications that are being explored within the foundation, not just prostate cancer. So why do we need a cost calculator? Well, first of all, as I mentioned, hospitals and manufacturers have little understanding of the true cost of a procedure. Therefore, it's difficult for a manufacturer to price its product because manufacturers look at pricing their products such that hospitals will at least break even. And it's difficult for facilities to compare technologies and their economics in order to make buying decisions for those technologies. So I created for the foundation a cost calculator. Some of these next slides are going to be busy. It just shows you what's included within this cost calculator. So basically, the first page of the cost calculator presents information about what it's for, how it can be used, where the information included in the cost calculator comes from, and then some disclaimers about the fact that this is data based upon what is readily available in the internet or based upon relationships that I have within the industry, but are not to be taken as true absolute costs. The second tab, this is all built in an Excel spreadsheet. The second tab goes through the directions for how to use the cost calculator. It looks complicated, but it's actually quite straightforward, and I'm going to go through that with you shortly. I just want to show you all the information that's included in the calculator first. So the calculator works off of a procedure database. Right now there are about 130 procedures in the database. These include both focused ultrasound procedures and the procedures against which focused ultrasound procedures compete. So for instance, for essential tremor, it includes open cranial surgery, deep brain stimulation. For prostate cancer, it includes radiation therapy, prostatectomy, cryotherapy, etc. And then for each of these 130 procedures, there are about 30 categories of information that are included in the database. These include whether the procedure is done in an operating room, under general anesthesia, how long it takes, whether it requires intensive care unit afterwards, what kind of supplies it uses, etc. The system also has information on the capital costs for each of the pieces of equipment that are used in the procedures documented in the database. So not only do we have the cost of focused ultrasound equipment, but we have the cost of radiation therapy equipment, robot for robotic prostatectomy, MRI unit, CT scanner, everything that is needed from a capital cost point of view is accounted for within this calculator. There are also facility costs. How much does it cost in the OR per hour? How much does it cost in the recovery room per hour? How much does it cost for a day stay in the hospital? How much does it cost for the fluoro suite, for the MR suite, things like this. So these are charges that the hospital incurs through use of facilities within the hospital. Personnel costs are included. These are taken from online resources, and they cover the hourly charge for each of the types of physicians, specialties, used in delivering these treatments, as well as radiology techs, nurses, OR nurses, intensive care unit nurses, et cetera. And then it has payment data. This payment data is based upon the most recent data available from CMS. This is all initially Medicare-based. I'll show you how to calculate private coverage off of the Medicare data. And it includes information about whether these procedures, while there is a payment for them, are actually covered. And finally, we have the wage index table and the geographic adjustment factor, which you can pull in order to adjust CMS payment levels based upon where in the country you are for calculating these costs. Okay, so this is where all the information comes from. What do you do with it? Well, the first thing that happens when you open the system and you begin is that you have a blank page. And we're going to create a cost comparison for essential tremor. So the first thing we do is click this box, and that activates this panel and indicates all of the different factors that are used and taken into account when calculating the cost for an essential tremor procedure. We then come to a pull-down menu, and from that pull-down menu, we select what it is we want to include in our coverage. So in this case, the first thing that we're going to include is MR guided focused ultrasound treatment for tremor. And included now are pulling from the database the cost for the capital equipment, cost for disposables, cost for the personnel that are used for this procedure, the actual cost for the time the patient spends in the MR unit. If there's anesthesia, the cost for anesthesia, nursing care, imaging studies, et cetera. And it comes up with a total cost for this procedure, as well as physician costs for the procedure if such is approved. And then we can also select whether we are going to just use Medicare payments in our practice or whether we're going to use commercial payments in our practice. And if we're going to use commercial payments, then we have three ways of representing the commercial data. We can simply enter a number that works for a given hospital for that procedure. We can enter a multiplier of CMS, or in this bottom panel that you see at the bottom of this page, we can enter the actual payment numbers for up to 6 different commercial carriers represented by that hospital paying for that procedure in that hospital, and then come up with the blended cost for the commercial payment. For the purposes of this comparison, I'm just going to do Medicare. So now we've added 3 other procedures. We've added deep brain stimulation. We've added open CNS surgery, and we've added a radiosurgery procedure. And these all get populated in exactly the same way. If we had added a geographic adjustment factor or a work adjustment factor in the initial procedure, that would be carried through all of the procedures, as would the distribution of commercial payments among a number of different payers if those were used. So as you can see, we've added additional procedures here. And then all this data is transferred to a comparison table. And the comparison table compares the costs for physician and facility and for the device, the payments for physician and facility, the net difference between what it costs and what is paid. We're looking for positive numbers as opposed to negative numbers. And then various coverage information. So if we look at the column on next, facility payments, do I have a pointer? I don't think so. It's the 1, 2, 3, 4, 5, sixth column over from the left. You can see that for a focused ultrasound for essential tremor, based upon the actual cost for the facility and the actual payment from CMS, the facility makes roughly $4,000. Whereas with deep brain stimulation, they lose $22,000. For CNS surgery, they make roughly the same amount of money, $4,000. But for a gamma knife treatment, they lose $4,000. So this information makes it possible for us as manufacturers to go to hospitals, or for you as physicians to take this information to a hospital and say, see, if we were able to do focused ultrasound, magnetic resonance guided focused ultrasound treatments for essential tremor instead of gamma knife for essential tremor or deep brain stimulation, the hospital would actually be making money instead of losing money. So this is a similar comparison table for prostate ablation. So I'm not going to take you through all the steps to get there. They're exactly the same as the steps that we went through for CNS, for essential tremor. But what you can see here is that magnetic resonance guided focused ultrasound for prostate cancer makes money, $7,000. Transurethral ultrasound ablation with the current payment codes and the current costs is around $1,500. Focused ultrasound ablation, meaning transrectal, is about $2,500. CyberKnife prostate radiosurgery is a losing proposition, and prostate radiation therapy makes money roughly equivalent to transrectal focused ultrasound ablation. But the critical piece here is that robotic prostatectomy loses over $10,000 based upon actual cost and actual payment for every single robotic prostatectomy that's done. Now, recognize that these numbers are just for Medicare. When we add in commercial insurance, the numbers change dramatically because the costs are exactly the same. But the payment levels can be anywhere from 150 to 400% more than the CMS levels, which is the reason why when you look at the literature, typically robotic prostatectomy loses about $2,000 to $3,000 per procedure. This is what is stated in the literature. But if you are a hospital where 80% of your patients are Medicare, you're going to be losing closer to $10,000 on a robotic prostatectomy. Okay, I'm going to finish up by showing you a comparison that I did to answer the question, how much money is lost by a hospital when we do a focused ultrasound, magnetic resonance guided focused ultrasound procedure in place of just doing magnetic resonance diagnostic imaging? Because typically hospitals will tell you, or radiology departments will tell you, we can't do your procedure because it's going to cost us too much money in terms of what we would get from doing imaging studies. So if a typical imaging study takes 20 minutes and you need our MR unit for 2 hours, that's enough time for us to do 6 MR imaging studies, which means we're going to lose money. They just arbitrarily say that. This here shows that that's not the case. All of the initial columns are the same, but there's an additional column on your right called magnetic guided focused ultrasound versus multiple MRI imaging studies. The payment for MRI imaging study is only, as you can see in this table, roughly $375. That does not include the cost of doing the MR imaging. So when you add in the cost of doing the MR imaging, the facility nets about $150. That's that first column there where it says MRIs. What this table does is it looks at how much time the MR-guided focused ultrasound procedure takes. It multiplies that 150 by that number of studies that could have been done instead, and then compares the profit from those studies to the profit that was obtained from doing the magnetic resonance guided focused ultrasound procedure. And as you can see, for essential tremor, for transurethral ablation, for prostate, you actually make money off of the MR-guided focused ultrasound procedure relative to doing MRIs instead. This is, again, from a Medicare point of view. Same thing applies to bone. You make a significant amount of money off of doing bone because the payment is so high, and you lose a significant amount of money for fibroids because the payment is so low. So in addition, in uterine fibroids, the fact that not a lot of those procedures are done being related to the fact that the gynecologist doesn't want to be in the MR unit, it's also a losing proposition for the hospital. Whereas for all the other possible uses of MR-guided focused ultrasound, it's a profit-making venture. So finally, the uses of this for manufacturers to be able to assess the financial viability of a new approach. Let's assume you're thinking of taking your technology and applying it to liver cancer or pancreas cancer or breast cancer. Does it make sense? All those procedures are included within the database. To demonstrate to customers, hospitals, the economics of the technology, and then as a manufacturer is designing its cost structure to determine how to cost procedures to maximize user economics. Ironically, and we don't have time to go into it, it turns out that hospitals oftentimes will make more money if you increase the price of your disposable, because by increasing the cost, you may move your procedure into a higher paying APC, which is disproportionately greater than the increase in the cost that you assign to the disposable. For facilities, again, assess the economics of purchasing new technology and to validate internal models of facility costs, which again, most hospitals don't do very well at. And then for physicians, to be able to have something that you can take to administration to justify the purchase of your technology. There are some terms of use for this spreadsheet. It's available to anybody that's involved in the foundation, all of our partners and members. All that we ask, it can be modified to suit your specific needs. So if you're only in the brain space, we can get rid of all the non-brain procedures. If you're only in the prostate space, all the non-prostate procedures. You can modify it how you want by putting data in, but a digital version of this is only available to you and you alone. You cannot share the digital version with the end user. So if you're preparing an analysis for a hospital, you can give them a plain hard copy of the output, but you cannot give them the digital version. And then what we ask you to do as payment, if you will, for this free tool is to keep us updated on the true costs that you find at the hospitals that you work at. We don't care about the name of the hospital, we care about the cost data so that we can continue to update the model in order to make it more accurate. And that is the end. Thank you. I think we have time for a couple of questions. No? No? We're done? Okay. Thank you very much for your time.